So friends, we are about to start a very exciting smart talk. It's the SMA AWR talk. And this talk is a fallout of a phenomenal talk we heard by Dr. Friedrich Kallinowski, who's now today going to be the expert. And his concepts were pretty mind-blowing. And after his talk, all of us have started thinking about grip and crip in whatever things that we do and whatever things we look at. But it was a complex talk, and we all admired the kind of complex work that has gone behind reducing the recurrence by studying the biomechanics of the abdominal wall, the mesh interface, and studying it scientifically, mathematically, and through an engineering perspective. But since the topic was pretty complex and we could barely get a grip on it, so our own founder president of the AWRSC, Dr. Ramana, decided to give a reprisal of this talk so that we could have a better grip on the script that Dr. Kallinowski was talking. And so today we have Dr. Ramana talking to us from his point of view of how we could understand the concepts and the principles put forth by Professor Kallinowski. And we have him as the expert, and we also have the famous Dr. deBeaux, will be speaking to us. And before Ramana begins, I would like Ashwin, my co-moderator, to introduce the speakers, and then we can start.
Good evening, friends. It gives me great pleasure to invite Dr. B. Ramana to invite the first lecture of the day. So he's going to try to simplify a complex topic which was delivered a couple of weeks back brilliantly by Dr. Kallinowski, and make us all understand what the biomechanics is about and how it is important to us in a practical perspective. So Dr. Ramana, he doesn't need any introduction per se. He's the founder president of AWRSC India, and he's also a big propagator of this AWR program in India. He's taught many of us. He's a great teacher. So here, over to his initiative to simplify this complex topic and make us all understand on the biomechanics. Now I request Dr. Ramana to take over and give the lecture, please.
All right. Thank you very much. It's absolutely wonderful to be here with all of you. And the subject is for the hernia geek. It's absolutely absorbing. And let me start by sharing my screen. And you just need to give me a thumbs up if you can see my video play. So ladies and gentlemen, let me start by telling you a short story. And here goes.
DJ. Interesting workout because we're going to be hitting bench and then arms. I'm just going to mainly hit bench for chest today just because I haven't benched over a week at this point. Feeling good. $275 is on the bar. Switch me lock it on. I've been procrastinating to make this clip really bad. I wanted to film the time of, right after it happened, but I just didn't have it in me. Wanted to film yesterday, the day after, but I didn't have it in me. And now I'm just like, kind of just want to get this out of the way while, you know, I'm still on a cast. I don't want to wait like months later and finally make a video or talk about what happened. But clearly I definitely pulled or seriously, severely strained a muscle, but I think I might have pulled a muscle between my pec and front delt, but I feel most of the stress within my arm a little.
So ladies and gentlemen, why does a muscle or tendon tear? And how do muscles respond to stretch, torque, and contraction, load bearing? So this is all the subject matter of biomechanics of muscles. And you know that the abdominal wall consists of so many structures like the linea alba, the rectus muscles, the obliques, and the TA, as well as the pelvic floor, diaphragm, and spine. All of these are connected, and the lay term for that is the core. And in fact, the America's Hernia Society currently is using core health as its USP. So all this is part of the abdominal wall. And you also know that in our patients, a stiff mesh or a scar plate or atrophic muscles are also parts of the abdominal walls of our patients. So all of this becomes part of the study of biomechanics of the abdominal wall. In the study of this subject, you will come across various terms which apparently sound familiar, and you can just go past it and read more. But if you really want to understand the subject, each of these terms has a very distinct meaning, scientific meaning, and it's good to have an idea about what each means. But before we go there, what problem are we actually trying to understand? Let's be very clear about that. We are surgeons dealing with hernia recurrence after mesh repair, and that's what we are trying to understand better, and we are digging deep into the subject. And that subject has been exposed by Friedrich Kallinowski, and I am trying to reprise his talk along with some of my own understanding of the subject. And subsequently, I'll throw this up for him and for all of you to critique me. I'm no expert. I'm just a keen student, and I'm trying to be honest about what I have understood. All right, let's be clear about this. And for those who don't know me, my name is Ramana. I'm based out of Kolkata, and I do a little bit of everything, and I'm specifically interested in hernia surgery. Now, the word reprise means to reiterate, to repeat. So I will be basically talking about the important issues covered by Kallinowski and repeat them maybe in a different way. And that way could be right or wrong. That is going to be interpreted by the author himself. Now, where does recurrence start? When there is a mesh, the mesh doesn't tear ordinarily, but the mesh tissue interface tears or it gives way, and that is where recurrence starts. Now look at this picture of a recurrent hernia, and you can clearly see that this is the right rectus muscle, this is the linea alba, and this is a thick mesh. You can see that scar plate. There's a tiny bit of the left rectus here, and the lateral part of the left rectus is here, and the external oblique is connecting the central component and the lateral component, but the deeper obliques and the transverses are disconnected. Okay, so the mesh is intact, but the interface between the lateral component and this edge of the mesh has got torn for whatever reason. Maybe the surgeon injured the nerves there and the rectus atrophied. Okay, looks like it. But whatever it is, the mesh and tissue interface has given way, leading to a recurrence. So this is one of the important things to keep in mind. It is a common notion both among surgeons as well as patients that once you put in a mesh, a hernia is cured for life. That is clearly not the case, as all of us must know. And we just have to understand why, okay? For this, we are going to go back to some basic school physics stuff, and I'm going to dumb it down to a level where somebody with my low level of intellect can understand. And I will now use this small video to explain it, okay? Imagine that you have a coiled spring with a length L, and you try to pull that spring, and the change in length is, say, delta L. So that delta is always a change. So that is what you're doing to a spring, okay? Now what happens is the spring tends to come back. So that is called the force of restoration, which is symbolized by Fr. So the longer you pull the spring, the harder it comes back. So the force of restoration is proportional to the amount of lengthening you try to inflict on the spring. I hope that is clear. So if it's a spring and you pull it longer, it tends to come back harder. It's an elastic material, right? So this is a property of elasticity. Now look at a rubber band now. Say it is a 1 centimeter thin rubber band, and you pull it by 0.1 centimeters. There, the restorative force is going to go back. So the rubber band is going to snap back the moment you release it, right? So this again is the same principle. What happened with the spring is happening with the rubber band. Now imagine you have a rubber band which is 5 times thicker, 5 times thicker rubber band, and you try to pull it by 0.1 centimeters, the same length. You will feel it's much harder. Your fingers will start feeling the pressure and will start shaking. Why? Because even though you're pulling it only by 0.1 centimeters, there are 5 rubber bands in lieu of 1 before. So if the force of restoration initially was 100 newtons, now it will be 5 times that, because you have 5 rubber bands with restorative forces of 100 newtons. So what is important to understand is that the restorative force is dependent on the cross-sectional area, okay? So it is, you know, in the coil spring, we saw that it's proportionate to the length, but here we are seeing that even though the length has been pulled the same, which is 0.1 centimeters, the restorative force is 5 times greater simply because it is 5 times thicker. So the restorative force per unit area is called stress. So this is a scientific way of defining stress, which is an important element of understanding for us. So when we are talking about stress on the muscle or the mesh or the muscle and mesh interface, we have to understand what we are talking about. Now, if we think that it's the degree of lengthening, if we just increase that degree of lengthening, then will that restorative force be greater? For example, if that rubber band is pulled, instead of 0.1, if we pull it 0.5, say 5 times, will it come back that much faster, that much harder? Not really. The reason is because the band is now thicker. We are talking about the thicker band. If you actually lay it lengthwise and you pull it 0.5 centimeters, then actually what you're doing is subjecting each one of those 1 centimeter bands to an increase of 0.1 centimeter only. So the effective change of length of each segment of the rubber band is only 0.1 centimeters. It's the same thing. So even though you have pulled the elastic material 5 times more, the stress has not changed because the length of this has also increased by 5 times. So therefore, a relative change in length is what is important to differentiate. Say, if you pull a 1 centimeter band by 0.1 centimeter, the change in length versus the total length is exactly the same as pulling a 5 centimeter band by 0.5 centimeters. And this change in length as a percentage or a fraction of the total length, initial length, is called the strain. And because it is centimeters of length, both above and below, it is a unitless dimension. So stress is a restorative force, which is newtons per meter square, whereas strain is unitless. So this is a fundamental basic concept in physics as I have understood it, okay? In terms of surgical understanding, I would say stress is the force on the mesh and or the tissue. Now that force can be perpendicular, that can be parallel, or that can be torsional. So it could be a twisting kind of force. So this is what is stress, the force on the mesh or repair. Now strain is the change in length of the mesh or tissue. So if you are subjecting the repair to a strain, it means that there is an amount of change in length, which means there is an amount of elastic stretching. So this is strain, okay? That is a response to stress. Therefore, if your strain is excessive, then it may overwhelm the strength of your repair. So this is my principle of understanding, that your repair is going to be as good as the maximal strain that it is subjected to. Now, when we look at repair, what are the factors that are helping that repair? What are the factors that are opposing that repair? Let's just look at it very objectively. So obviously, a mesh is going to help your repair. That's very clear. How well that mesh integrates with the native tissue is going to be a dominant factor. Why are these two separate? Because in the initial phase, when you place a mesh before integration has happened, the mesh physically forms a barrier to herniation. So it is a factor which is part of the repair. Whereas once healing starts, the mesh and tissue interface becomes the important factor in helping the repair. And lastly, the fascial closure has to heal biologically. So these three things are the most important factors helping repair. Factors disrupting the repair are raised intra-abdominal pressure like sneezing, coughing, vomiting, bucking, straining, etc. And those with raised abdominal wall thickness or reduced abdominal wall compliance. So that exerts a disrupting force on your repair. The basic thing that we have to understand is that the mesh should not move. This is very clear, right? All of us as surgeons don't want the mesh to be in somewhere else. Like you do an umbilical hernia repair, you don't want to wake up and find the mesh in the inguinal canal. So the mesh remaining in place is a principle in physics called stiction. Now, stiction means the force you need to overcome static friction or stiction. So think of it as two surfaces sticking together, the mesh and the tissue. If they are very sticky, then the amount of force you need to use to overcome that stickiness is the force you need to overcome stiction. So this is a principle of physics that is at once important in orthopedics as well as in general surgery. For example, if there is a broken bone, you need to bring the two ends of the bones close together and put a fixation wire or a nail or a plate and keep them together in place and wait for biology to take over. So physically, you keep them still in one place while the body's inflammatory response kicks out and starts creating the union between the tissues, and in our case, between the mesh and the tissue. So this is fundamentally what we need to do when we are doing hernia repair in terms of principles. Now, there was a Polish study a few years back where they used multiple cameras to check whether the mesh stays in one place after being implanted. They used thin male patients because in fatter patients, it creates some confounding issues. So they used cameras and computers to devise models. So what happens to mesh when you turn around, when you bend sideways, or when you lean this way or that? So what they ended up finding was that the mesh is also subject to these torsional stresses, as is the rest of the abdominal wall. So there is a change in the shape of an implanted mesh. So even if this is an IPOM, if you are turning around, bending, twisting, then there is going to be some torsional stress on the mesh and the mesh tissue interface. Now, the linea alba is an elastic structure and exhibits a quality which is known as anisotropy. Now, anisotropy means that the linea alba is more stretchy in the longitudinal direction, less stretchy in the horizontal direction. And it is more stretchy in the upper part and less stretchy in the lower part. Now, this allows someone to do movements like this. It gives you greater flexibility in adopting different positions in life and is a part of movement. So this is a flexion movement, extension movement, I'm sorry. And this has been well studied in literature, and this is also important to us. Why? I'll come to that. Let's just look at what happens if you use a very stiff mesh, say a microporous heavyweight polypropylene mesh, versus a very, very lightweight mesh, maybe 25 grams or 30 grams of weight, okay? Now, the difference in the results is something most surgeons would know. The stiff mesh may create pain and tightness. It might feel restrictive. When there is a bend, the patient might feel that the mesh is bending or folding and he feels uncomfortable. Whereas a really soft and lightweight mesh may actually tear, or if the defect is not closed, it may actually get pushed out into the hernia sac or under the skin. So on one hand, a stiff mesh creates pain and stiffness, and on the other hand, a soft mesh can lead to recurrence and eventration and rupture. So the abdominal wall is anisotropic. It is more flexible, more elastic in the craniocaudal axis and less so in the transverse axis, okay? But what happens to the mesh? Now, this is a polypropylene mesh. You can see it is stiff on one side and rather elastic on the other side. So this is a quality of mesh called anisotropy. So what is the importance of this? If your linea alba and the longitudinal axis of your abdomen is more flexible, more stretchy, it makes sense to put the mesh such that the stretchy part of the mesh lies in the cephalocaudal axis and the stiffer part of the mesh lies in the horizontal axis from flank to flank. Now, what happens if you don't do this? It is likely that the mesh, which is on the stiffer side, if you place it cephalocaudally, you will potentially have a recurrence at the edge of the mesh, because while the linea alba and the upper abdominal muscles are stretching out more, the mesh is not. Therefore, the stress and strain at the mesh tissue interface is likely to be higher, and a recurrence might happen there. Okay, so this is the importance of anisotropy of the abdominal wall as well as of the mesh. Now, why then we need to know, do hernias recur over a period of time? Okay, if there's a technical error, it can happen right there. Now, the impact of dynamic forces which are always seen in the living human being, whether from coughing or sneezing or because the patient is overweight, those forces are excessive. So coughing and sneezing may take intra-abdominal pressures as high as 250 or even 290 millimeters of mercury. So that is enormous amount of increase in the pressures and not supposed to be felt by a repair normally. But that is how it is. So Kallinowski has come out with the concept of grip, wherein this is studied, the effect of raised intra-abdominal pressure and the intermittent rise in pressure. How does it affect? Can it be studied? Can it be replicated in vitro? Is part of the study, which is called the dynamic intermittent strain. And what we have seen is a bench test, which studies the characteristic of various meshes and various fixation devices against repetitive stress like a cough. Now, one thing about a cough is that it has been studied that while the pressures may rise up beyond 200 millimeters of mercury with every cough, a patient in the postoperative period may have as many as 400 such episodes in a single day. So your repair may be subjected to dynamic intermittent strain for as many as 400 times in one day. So this has been studied methodically in the lab. Now the machine is like this. It's a cylinder made of aluminum, and a hernia model is placed on it, and it is connected to a computer which records the pressure. Now, where is the rise in pressure coming from? It's coming from some sort of pump which is pumping in air into this cylinder. And this is the lid of the cylinder, and the hernia model is basically a piece of pig belly, and I'll show you that in a bit. Now, this is a pig's abdominal wall from the inside, from the looks of it. So the surgeon is taking down the bladder and exposing the linea alba and the anterior abdominal wall. So the bladder is going to be moved out of the way. Okay? She's also saying, I'm very good looking and very talented, but that's in German, so it's okay.
Oftmals nur eine ganz dünne Schicht für die Faszie vorhanden ist. Und wenn wir zu viel wegnehmen im ersten Ansatz, dann kann es uns passieren, dass wir hier einen Defekt haben.
So she says she's going to make a defect on the abdominal wall. And this is how it looks. So if you see this, this is a defect 5 centimeters in size probably, with a Dynamesh Sikat mesh fixed with absorber tanks. And the entire anterior abdominal wall is fixated to this silicone piece, which is on the roof of the device. So these plastic fixation tools have fixed this entire model to the lid of that cylinder. And there is a pump which pushes in air at measured pressure of 200 or 250 millimeters of mercury multiple times. And the rise in pressure is recorded and the mesh behavior is observed. I hope you understood that. Look at this. This is looking at it from the top. So this edge is the muscle of the anterior abdominal wall. There is a defect which is underneath it. The mesh is placed under this, and this is like a skin, and this gooey material is probably vaseline, so it makes it slippery. So you're trying to see the grip of the mesh and the fixation in response to repetitive strain, repetitive rises in pressure inside the chamber. And you see that the mesh is getting eventurated out every time, okay? So the ability of your repair to resist dynamic intermittent strain is the grip factor, okay? So the grip factor is going to be critical in bringing good outcomes to your repair. When you do this study, you can see after repetitive stresses and strain are divided on the model, the mesh tears at the edges and then gradually migrates to the center of the defect, okay? And there are many observations in studies done by Kallinowski. One of them is that if the hole is bigger, then the mesh tends to get detached faster, and you need more fixation to hold certain meshes, and so on and so forth. I'll come to that maybe in a bit. So one of the things that I thought of as a concept in my mind, and I'm sharing this with you, and if anybody has said this already, I apologize, but this is original from my mind, which is that a hernia recurrence is a single site event where at one point in the mesh tissue interface, at one point, the shearing force is overwhelming the grip. So wherever in that repair, that weak link in your chain is going to define your repair. So if it snaps at one point, that is the beginning of the end of your repair. Now, multiple meshes have been studied, and what is remarkable is that meshes like the physio mesh, which had bad outcomes and were withdrawn from the market, they had predictable bad results in the bench test in this model. And those meshes which have better behavior to these repetitive stresses seem to be doing better. So that at least looks to be related, though I would say it's probably not conclusive. So grip depends on largely three factors. One is the mesh. So the mesh can be slippery. Say if it's a coated mesh, let's think of Paritex composite. Maybe it's slippery on one side and not so slippery on the other side. Or physio mesh was very slippery. So on the other hand, you have something like a pro grip, which has tentacles. So you can say that it will be the least slippery. In fact, when you try to implant it, once it gets stuck to the tissues, it's pretty hard to rip it out, right? So I would say that the grip factor of a physio, of a pro grip is going to be higher. And some other meshes like the PVDF mesh by Dynamesh called CCUT, that is also a mesh which has a high grip factor in these tests. And clinically, if you use it, it also feels that it sticks well. What is the quality of your tissue? Thin, atrophic, flimsy, or strong, good facial quality? That is going to decide. And fixation. Is your fixation weak? Is it good but too few? So on and so forth. Now, what exactly is grip? We've understood things like stress, strain, anisotropy, all of these things we've understood, right? What is grip? It is the ability of a mesh to withstand dynamic intermittent strain. So I hope Friedrich is watching and will correct me if I'm wrong anywhere, because this is my presentation as a student. I feel like a high school student actually. So the higher the grip, the better the results of your mesh repair. Okay, mesh per se slips on peritoneum. Peritoneum is slippery and some meshes are slippery. So mesh on peritoneum needs to be stabilized, let's say. Okay, so what are the factors which can affect the grip of a mesh and how can we influence them? Okay, the first is you can fix these slippery meshes on slippery surfaces with your choice of fixation. So you can use absorber tack or metal tacks or sutures or glue. Now, how does this matter? Does it? Yes. Absorber tack gives poorer quality fixation. So if you're using absorber tack, you should use many more than if you were using, say, tacks. And if you're using sutures, transfixational sutures, transabdominal sutures, they are probably the strongest of fixation methods. So you don't need to use as many as you need to use absorber tacks and regular tacks. Now, if you're just thinking in terms of the defect size and fixing your mesh, you would probably be underestimating your need for a more elaborate repair. The area of instability in the abdominal wall, and remember I showed you some images from that Polish paper where there is a lot of stress and strain happening over the abdominal wall after surgery. So that area of instability is larger than the defect size, defect area. So you have to cover that part adequately with your mesh, okay? And the defect size is a critical factor, as we all know that the bigger the defect, the more unstable your repair is going to be, the greater your chance of recurrence. So obviously you would need to bring in a greater amount of grip into your repair in a larger defect size. So if it's 5 centimeters, it's one level of game. And if it's a 10 centimeters defect, it's another level of repair altogether. Now, apart from this, are you closing your defect properly? Are you leaving it as such is going to be a big issue, because we all know that defect closure has a very, very positive outcome in terms of recurrence and quality of life. The number of fixation points is important. Have you ever wondered why a Pro Tack or a Capture has 30 screws in it? Okay, you can tell me that some of them may have less, but that's okay. But you probably need that many for an average 15 into 15 IPOM. I think that's the indication for designing that device originally. Probably they thought of IPOMs first, and that was the size probably at that time. This is just my guess, okay? So the number of fixation points needs to be higher to increase the stability of your mesh, okay? And lastly, in this particular slide, I will say that what type of mesh, coated, uncoated, polyester, or PVDF, or polypropylene, and what size of mesh, is it 50 into 50 or 15 into 15? Everything matters when you're talking about the grip. The other factors, these are the last two factors which are affecting the grip, is tissue distension, which presumably means the distension on the anterior abdominal wall. I do not really comprehend the role of tissue distension as such. The other is the location of the mesh in the abdominal wall. So an onlay would be less stable and a retromuscular sublay or a preperitoneal mesh would be more stable. So this is a list of all the factors that can affect the grip of mesh. Now, the advantages that Kallinowski says the grip concept has are listed here. You can actually plan your repair. If you think your mesh needs to be a stronger one or one with a higher grip, you can choose that. If you need more fixation, you can plan it. You can tell the patient you're going to have greater pain, so on and so forth. However, all this genius level work does leave me with some troubled thoughts. Okay, I have some problems with this concept of grip. What about the retromuscular space and, say, for example, the ETEP repair? Kallinowski has done some recent work on the Milos technique and has studied it, though we really don't know that in too many details. But the concept of grip, whether it is the same when it is an IPOM, when it is a sublay mesh, when it is in a tar plane, doesn't seem to be making sense to me, because the dynamics has to be different in different planes, and the concepts will also have to be matched according to where we are placing the mesh. So one thing that comes to mind is that this is a very complex subject for the average general surgeon to implement. So as he says that you can plan preoperatively the grip and how much your grip should be, I don't see it happening with the average surgeon. I think there needs to be an algorithm, a better way for the clinician to incorporate it. Okay, so you have this patient, you have to do 1, 2, 3, 4, 5. Therefore, your grip factor is going to be, say, 36, and you're going to have a close to 0% chance of recurrence. Otherwise, I see this as just an academic exercise with some implications for some people. As I said, in the tar plane, when we put in gigantic pieces of prosthesis, we put in, say, a 50 into 50 centimeter size mesh from flank to flank, from central tendon of diaphragm to the pelvis, and the defect is closed. I do not fix the mesh at all. How is the grip going to be? Shear overlap, can it make up for lack of fixation? To what extent? If the overlap is, say, 7 centimeters or 10 centimeters, does it give enough grip, just the overlap without fixation? Or will that cause a recurrence? I don't know the answers to these questions, but this does come up as an important question to me. When we put in these big meshes, the classical school coming from Henniford and then Mike Rosen, Urinovitsky, all of them have been doing quadrantic fixations, and most of them still do. Mike Rosen, to my knowledge, still believes in fixation. However, a lot of us have come to the position that if your repair is good, you're following AWR principles, fixation may be overrated. I'll continue with this thought that maybe we will never know the truth, but the pursuit of truth, like the pursuit of happiness, has to come from shorning away, throwing away all that is unnecessary, all that is fake, all that is pretense. Only when we embrace the fundamentals can we get closer to the truth, and the same way closer to happiness. Thank you very much, ladies and gentlemen. I will invite you to an international online conference on the 7th of November with ANZ Hernia So that's ANZAR 2020. The theme is controversies in hernia surgery. And I would be delighted if all of you come in and participate. So that's it from me. Thank you very much.
Thank you, Dr. Ramana, for that wonderful talk. I now invite Dr. Friedrich Kallinowski from the University of Heidelberg, Germany, a pioneer in biomechanics, to give his comments and further add inputs as well. Over to you, Dr. Kallinowski.
Hello. Ramana, I think I've never in my life heard somebody so quickly grasp 7 years of experiments and transform them into a genius talk. I really have to say this. Congratulations. I mean, this is very, very excellent. So let me just try to point out a few things. One of the things is the concept of the mesh defect area as given by Tullow and deBeaux, and I'm sure he will talk about it in a moment, is sort of the base. They had a theoretical consideration on published data from Houters. The data were published in 2010 and the consideration was 2016. And for us, this was very important to transform all that sort of observed instability into a concept which we call the gained resistance to impacts related to pressure. So this is the gained resistance to impact related to pressure, which we acronym to GRIP. So when you do a repair, you want to gain enough resistance or resistive force, as you pointed out. You want to gain enough resistive force to surpass the critical resistance needed to impacts related to pressure. So in your individual patient, in your individual hernia situation, you know, defect size, defect location, sort of recurrence, yes, no, patient overweight, yes, no, patient with lax tissues, frail and bad healing tissue, and so on. All of this goes into a critical resistance. And if enough people would be interested, we could put the critical resistance and the gained resistance into an algorithm. I'm in serious talks with a small upspringing company in Germany to put this into an algorithm so every surgeon could sort of calculate for himself from the factors he knows for this given patient, for this given mesh, for this given situation, to reach those two values. What do I reach when I look at this patient with this type of fixation? So this would be the critical and the gained resistance. Both sort of, they sound like grip, you know? So grip, I don't know. So I think this is a very good thing that Tullow and deBeaux published this theoretical consideration. And for us, you know, the next step could be, if there is enough interest in it, to make an algorithm to make it clinically more applicable. So if you look at the bench test, it runs on water. This is important for everybody who wants to do a similar machine. I mean, this is just, we have now two prototypes, two different sort of machines. They have a different design. They have a little different results, about 10% in average. So, you know, there is definitely more to come in these type of machines, because I agree, we had, in the last 7 years, we had 70 new meshes. And we should know as surgeons, are they slippery or not? Do I need fixation, yes or no? So if we want to build those bench tests, we should build a hydraulic design. You know, we will not be able to do it with pneumatic, with air, because air is compressible, and this is how the brakes of your car work. If you have air in your brakes, you will have an accident. So, you know, you do not get repetitive strain on a pneumatic design. You need to use hydraulic. We used water, but there might be other types as well, oil or other fluids, I don't know. So this is a technical development on the bench test side, which probably will be interesting for the next years to come. So you asked about, are there other influences on the grip concept we do not know yet? Yes, definitely. We are not at the end in this concept, you know. Maybe we do have some kind of an overlap factor in 2021. We are doing a series of experiments running now, and since it's all relative, you know, we do not have how many newtons per square centimeter do we have. We have no tissue distension, measurement, and these kind of things on our bench test. All of these could be developed, but they need, again, an investment, and people need to be interested in this. So there are other influences not yet described, and this has to be kept in mind. But at this point in time, the concept is clinically applicable, and it takes about a day course for a surgeon to be trained in it, to calculate it for himself. We have done it with 20 German surgeons. They work in 10 German hospitals, and they all produce the same results. So it's not sort of very fancy mathematics, you know. For the surgeon, it's, as you said, secondary school level mathematics, you know. It's multiplication, and you add some figures, and so in the end you get your gained resistance to impacts related to pressure. Now you had, I think it was 6 different questions, and I want to answer these questions. One of the questions was retromuscular space. The retromuscular space is a space which depends very much on your preparation. If you have a very careful dissection and little fluid extension, you will have more mesh tissue interface than in the other side when you have seroma formation. If you have seroma formation, you have a disconnection of the mesh and your tissue, and then it's probably wise to have fixation to keep the mesh connected to at least one side of the tissue, because seroma starts to lift the mesh in this area and creates a weak spot. And as you pointed out in your talk quite correctly, that if you divide your abdominal area, let's say clockwise, you have between 1 and 12 different areas. And if you analyze this, and you showed the slide in one of your previous talks, I've looked it up in the AWR video series, and I can recommend to everybody to look this series up. It's an excellent educational tool, and I learned a lot by looking at it, just from the technical point of things. But besides this, you showed a slide there on a computer tomography of the abdominal wall with different instability representation. In one, it was a representation just for the area of the hernia, and in the other one, it was a representation of the instability zone. And you saw that that zone was quite differently spaced. In this slide you showed it was an instable area at about 10 o'clock. So at about 10 o'clock, this is the weak spot, and there you probably need to put in fixation. So it depends what you have, you know. It's not sort of a question of fixation is good or bad. It's a question of, do I have seroma formation, and do I expect problems, and do I have unstable areas? The same is probably true to your second question about different planes. You know, the different planes, they have different friction forces. As you pointed out, peritoneum, it's slippery, and muscle, it's more rubbly, and tension can be slippery. We did it with 2 different lubricants. We used phospholipids and different oils and so on. And so you can experimentally look into it, very interesting, but in the end, for different planes, you will get different sort of plane factors. You know, the plane you put it in will have a cumulative factor. And at the moment, if you put the same piece of mesh in the IPOM position, you will have a 0.9. And if you put it in the sublate position, you have a 1.0 for a fixation factor of the mesh. You know, you said pro grip, it's 1.44, and dynamic thicker, it's 1.0, and physio mesh was below 0.1. So they all have different factors in the end if you repeat the experiments frequent enough. You said too complex to be implemented. This could be surpassed with an algorithm or with some training, you know. And this algorithm can be put on a handheld or an Apple iPhone or something. It's not really a problem. You put in 7 figures, you know, as we put it in our stronghold registry, and it takes about a minute to calculate it out. If you believe this is the way to go, or you take a day and we share some time and discuss things, and yeah, can you do it for yourself? Can overlap make up for zero fixation? Yes, if you have a non-slipping mesh. You know, at the moment, for most meshes, we do not know the slippery or the gripping factor. If we would know for the 140 meshes on the market, the gripping factor, we could much more easily decide which ones we need to do fixation on and which ones we do not. So at the moment, for the meshes we use, we do know the fixation factors, and so we just apply it to the given situation as detailed already. And you said fixation is overrated. I think it's not a question of fixation, yes or no. It's more a question of, do I need fixation? And if I do need fixation, how strong do I need the fixation to be? And how do I need to apply it? You know, it's like when you construct a bridge. You construct a bridge and you say, I need 5 rows of ropes and 3 rows of bolts to bring the strength in the material, and the strength of the material is high enough to hold the 400 meters the bridge has to span. You know, this is sort of engineering. These days, it's general engineering. They all learn it in their basic studies. Every engineer knows this. And for the surgeon, it's a completely new field. And for us, I think it's time to sort of think about how to integrate this kind of thinking into our application to abdominal hernia reconstruction. Having said this, I think there is something we need to point out. There is an important difference between steel and concrete and rubber and tissue. In the slide you showed, you sort of made this very brilliantly, but I have been putting in cells and fibers and intermediate stuff, you know, and I put this in because in soft tissue, the stress-strain relation is not in a strict sense true. Tissue is like a chameleon, you know, it's soft when you pull it slowly and it's hard when you push it hard. It's like water, when you dive in from 10 meters, it's very, very strong. It's almost like, you know, when you hit it not on the right angle, you know how strong the water is. But when you sort of sit in the water in your bath tube and you play with it, it's very soft and very, so this is like soft tissue is. It's a chameleon, it's soft and hard. And the current or developing theory on this, we exchanged ideas on it. You remember our WhatsApp conversation on the point. It's probably a hierarchy of weak inelastic bonds, which are constantly broken on both a microstructural, a cellular, and a macrostructural level and rebounded. It's not like we thought that two fibrin filaments stick together and that's forever. You can break them, and there are direct observations. You can look at the videos, how people do this on a micrometer level. This is very gripping when you look at it. And a guy who is a physicist named Klaus Greu in Leipzig in Germany, he's about 300 kilometers away from, he published on this on a theoretical basis, and I think there are much more things coming in the future. So I congratulate Dr. Ramana really for translating a very complicated topic in an astonishingly rapid and quick time. You grasp this in a very short period of time and you transported it. So I understood very clearly what you meant. Also, I might have known some of the sort of basic ideas behind it already. Thanks a lot for presenting this.
Thank you. Thank you so much for the appreciation.
So I would now request
Thank you, Dr.
next
Kallinowski,
speaker,
and
Dr. Andrew deBeaux from the Royal Infirmary Hospital of Edinburgh. So he and his team have actually single-handedly changed the concept that mesh overlap should not be measured in centimeters. Rather, they brought about the important concept of area and mesh defect ratio. He's also a pioneer about the peritoneal flap herniaplasty, and they've shown how good their results are. So now probably he would take us into his talk and show us how the abdomen is not only going to be measured on a single tendon concept, rather it should be taken as a whole cylinder. Over to you, Dr. deBeaux, for your talk.
Thank you very much. I am having some technical difficulties here with my sharing, so why don't you just talk amongst yourselves while I try and sort out this issue, and I will get back to you shortly.
Are you using
I would request Dr. Ramana to just have a word with Dr. Kallinowski, and if he has any answers to questions to Dr. Kallinowski, you could probably use this opportunity.
Okay. Fine. So Alex Karatasas is a senior surgeon, primarily into hernia surgery, robotic, and colorectal surgery in Adelaide. Alex has brought out a very, very important aspect of the biomechanics, and he's mentioned that mesh tissue integration is a very, very important subject, MTI. So it depends on many it's not something one can just touch base and go. I just paid homage to it during my talk at the initial part and said that the mesh has to integrate with the tissue, and that is going to be one of the most important factors in the grip. But how? What are the factors that help the mesh tissue integration, and what are those factors that resist or prevent it? For example, biofilms. If your mesh is covered by seroma, and there's a small nidus of bacteria which gets in there. Say if you have a macroporous polypropylene mesh, probably nothing happens. It just, the body takes care of it and nobody knows anything. Or in a specific patient, there is a mild amount of cellulitis or inflammation, and that gets taken care of with some antibiotics and just wait and watch, do nothing. But if you had a polyester mesh, just that tiny bit of inoculus may actually lead to a much more clinically significant infection going all the way till reoperation and mesh explantation and recurrence. So it could well be an absolute disaster depending on what mesh you're talking about. The same way, if you have a seroma after an IPOM and that seroma gets infected, there are surgeons who are very impatient. So if the patient comes back with a worrisome swelling, which is basically a seroma, there are any number of surgeons who are quick enough to put in a needle and aspirate it and introduce infection there. So if you have an IPOM mesh that gets infected, it's not going to behave the same as a polypropylene mesh which is getting infected in a different space, even in a non-lay space. So an IPOM mesh may form a biofilm much better because the adhesion prevention coating or gel, whatever it is, has a lot of these polysaccharides which basically are food for the bacteria. And the bacteria quickly starts secreting more slimy material and they kind of cocoon themselves from antibiotics. So your antibiotics won't reach the bacteria inside a biofilm. And if there is a biofilm, the mesh tissue integration isn't going to happen. So these are the settings for invasive infection and multiple interventions and bad outcomes. So that is what I had to say with regard to Alex's topic. It's very interesting and important, and maybe we will talk more about it one of these days. Yes, Andrew.
Good afternoon. I'm back. I don't know if you can see my screen.
We are able to see your screen, Doctor.
Fantastic. I do apologize for that technical mishap. Do you want me just to keep going?
Sure,
Might as well, in the interest of time. So I would like to, this is the topic that I was given, and these are my disclosures. And what my plan to do today is to talk about 3 operations that we have thought about related to the parameters around biomechanics, some of which you've heard already, and see if how we've influenced things along the way. Now, I will be presenting a lot of ideas and beliefs, and part of the problem of ideas, and they're very nicely put, if you're wanting to have a little insight into the human mind, have a read of this book, The Impact of the Highly Improbable. And I'll read this, and I don't apologize for reading it. The problem is that our ideas are sticky. Once we produce a theory, we are not likely to change our minds. And that sentence probably encapsulates surgeons in general. But I would like to pay a tribute to Dr. Kallinowski for his work, because he has often taken some quite childish thoughts of my own and my colleagues and made them into real science. And I know Ram has put together the concept of grip, and we've heard from that. But essentially what grip is asking you to do is think about how big's your mesh, what mesh are you using, how are you securing it, where are you putting it, and what are you doing to the tissues as you bring them over or underneath the mesh. And bear in mind that your hernia size has a big impact on what you do. And if you just grasp that what you do is important, grip is actually relatively straightforward. And while it can become a mathematical issue, well, if it's 5 centimeters, I do this, and if it's 6 centimeters, I do that, that's maybe taking away some of the art of surgery of getting it right by just doing it right. Now, I want to talk a little bit about IPOMs to start with. And I talk about our journey because a lot of what I was involved in is also due to my colleague, Bruce Tullow. And this was us at the Oscars. I can't remember what award that was. But anyway, we started IPOM about 2003. I can't really remember. But we were pushing the boundaries. In fact, I was the first surgeon in Europe to put Proceed into a patient. So we got Johnson & Johnson's mesh first in Europe. The Americans beat me into humans. And we were bashing away with IPOMs. But by 2010, we had published on our own observations about pseudo-recurrence that the results were not as good as we thought. And here we can see pseudo-recurrence. Here's the tax. We can't see the mesh, but this mesh is a lovely contour shape of the abdominal cavity. And the patient has come back saying, I've got a recurrence. People used to be naughty and do CT scans and say, no, the mesh is in position, it's not recurred. But as far as the patient is concerned, it's recurred. Now, we didn't make up the term pseudo-recurrence, but we popularized it. And this was our early results. We had 163 patients. We could only follow up about 3/4 of them. Very few recurred, but 14 of 121 is over 10%. So roughly 1 in 9 of our patients came back with a bulge that they thought was a recurrence. So immediately we were thinking, this is not very good. We need to do better. And this was part of the problem. This, in our early days of IPOM, was an easy case. There was no reduction of contents. The abdominal wall looked good. We would stick a mesh in and fire some tacks, and the job was done. But we were starting to get an idea that that wasn't the right way forward, and maybe some closure or narrowing the defect, and we came up with these spider's web sutures to try and stop the mesh slipping into the abdominal cavity. And here's another of our patients. Again, we didn't put the mesh in eccentrically. It would have been centered, but it now follows the curve of the abdominal wall, and clearly that patient has a recurrence. And this is more of a reminder of me when I'm sitting next to the Queen in my kilt. Pseudo-recurrence is good with a kilt. It's terrible when you're wearing a kilt. So this is how we want our mesh up against the abdominal wall, but remember, pseudo-recurrence has its benefit when you're wearing a kilt. Now, it was interesting, in 2012 was the joint meeting of the EHS and AHS, and I was speaking last in a session of 5 speakers, and the previous 4 speakers all spoke about pseudo-recurrence and quoted our paper. And it's obviously quite upsetting when you actually have to say, well, this paper was actually our cases that didn't go very well. But this is a slide that I presented in New York in 2012, when this concept of the mesh defect was starting to come into our heads. And we heard a lot about 5 centimeter overlap. I'm not sure where that came from. Carl LeBlanc, one of the early pioneers of IPOM, talked about 3 centimeters. He then said 5 centimeters was better. He never said that 5 centimeters was the perfect overlap. And people very quickly latched onto 5 centimeters because a lot of surgeons don't think too carefully and they want an easy number. 5 is a nice number to remember. So 5 centimeters overlap, you're cured. And we did these very simple calculations on paper. You've got a 1 by 1 centimeter defect. So 5 centimeter overlap, you've got 11 by 11 mesh. Remember, the diameter of a mesh, the area of a mesh is pi r squared. So dump pi. So half of the radius is half. So half times a half is a quarter. Half of that is 5.5. 5.5 times 5.5 is 30. And you get this mesh area ratio, a very large sum. We got to a slightly bigger defect, 2 by 2. That becomes 1 by 1 squared. That's 6 squared, 1 to 36. And then we go from a 1 centimeter defect to a 4 centimeter defect. We do the calculation again. We now have a mesh defect ratio of 12. We've gone from a 1 to a 4 centimeter defect, a small hernia to quite not so small, but we have had a 10-fold reduction in the mesh defect ratio. Then if you could narrow it a little bit, you could make an impact. So we were starting to think, maybe this has got something to do with it. What we also noticed was when we looked at our IPOM results, if you had a small defect, and this was the standard size mesh we were using, we had 0 recurrence. So we thought, big mesh, small hole, we're onto something. So we wrote up this paper. It was a long paper, and we submitted it to Hernia. And the concept in our head was you need a mesh defect ratio of 16. This was a theoretical calculation. So the radius of your mesh, or your diameter, doesn't matter, but the radius is easier for maths. The radius of your defect and the radius of your mesh needs to be, the radius of your mesh needs to be 4 times the radius of your defect. So in we went, we submitted our paper, and it was rejected. Two of the reviewers said this was rubbish. We already had good guidance. You needed 5 centimeter overlap. So this was just mathematical nonsense. But one reviewer had an idea that maybe we were onto something. So we thought, well, let's try again. So we resubmitted our paper as a short communication. We took a lot of the science and maths out of it, and we fired it back, and we got it accepted. Now, instantly, this reviewer was Philippe Heuters, and he had some data. And he said, well, I've got some data. Let's try it out. So these were IPOMs, no closure. He had good follow-up and he had some recurrences. Did some univariate analysis, and these were the factors, including the mesh defect ratio, that were important for recurrence. But on multivariate analysis, the mesh defect area ratio was the only factor of note. And this was the final science. If your defect ratio was less than 8, your recurrence was almost guaranteed. But as the mesh defect ratio got bigger, and his was the magic cutoff of 17, you could then have recurrence down to 0%. So what did that mean? Well, that meant for a 5 by 5 defect, for an area ratio of 17, you need a mesh that's 20.6 by 20.6, or the overlap is 7.8. So the bigger the defect, the even bigger the overlap, and forget 5 centimeters. And it was absolutely thrilling for me when I met Dr. Kallinowski in Vienna in 2017, that he came up to me and said that the mesh defect area ratio is a pillar of abdominal wall repair concepts. Maybe I'm over exaggerating, but it was an interesting concept. I'm going to move rapidly on now, just in the interest of time, to small ventral hernias. And this is a schematic diagram. It's not my diagram. It's been stolen from a plastic surgeon from Canada, whose name escapes me. But if you put a strain on tissue, so you stretch the rubber band or whatever, you will get stress within the tissue. And if you have a hole, like an umbilical hernia, you'll have lines of stress as they go round the hole, will get closer together. The closer the lines of stress are together, the greater the stress at that point. So you come along and think, all right, I've got lines of stress, I've got a little hole, let me close that hole. You are closing round lines of concentrated stress or high stress, and you're pulling together tissue that's already stressed, it's quite likely it would fail. But if you could expand the load of that stress, so you would start higher up and bring your suture down, you're then starting your suture at relatively low areas of stress, crossing the high areas of stress back to low levels of stress. And maybe that will produce a better repair. So we came up with this concept of, well, let's not close the hole in a sense. We're dealing with areas of high stress with small holes. This is a 1/2 by 1/2 centimeter defect, tiny little epigastric hernia. And let's do a darn. So you start off with a long suture up here, and you go through, you come back, then you come back through the hole, then you come back. So you've done 5. They always have to be an uneven number of rows, so you finish off diametrically where you started. And then to finish off the weave, we go up, down, up, down, up, down. And obviously the bigger the defect, the more crosses. This is like darning your socks. For the older of us, when our grannies taught us to darn our socks, this is how we darn our socks, and we tied off the thing. This is called our darn for less than 2 centimeter hernias. Now, we haven't done a lot of these over the years because we still are great fans of mesh. We still do quite a lot of IPOMs, but this is a good technique for patients who don't want mesh, who only want a suture repair, or perhaps are not so fit, so you want to do it under local anesthetic. So we recently had this paper accepted. We've done many more cases than 47, but you need decent follow-up. So the ones we've done in the last few years, we can't include in this study. So this is decent follow-up. Understandably, we lose some patients, some people die in an intervening period. But for these defects, suture repairs with a 6-7 year follow-up on average, we have a relatively low recurrence rate. So there seems to be some element of not forcing tissues together that is under stress, spreading the load, and this is a technique to help. But obviously, I can't give a talk without talking about the peritoneal flap repair. And I'm not saying it's the only way to fix a hernia. It's just a very useful operation to have in your toolbox. And I want to spend a little bit of time talking about the poor old linea alba. Now, linea alba in most CTs, and this is a standard CT, there's nothing wrong with this patient, or the CT scan was not taken to look at their abdominal wall. And you can hardly see their linea alba. Let's magnify the view. It's a tiny, thin, scrawny little structure. And so suturing linea alba together is not a great way of dealing with the abdominal wall. So cutting it is not a good plan. And that's why maybe incisions that avoid linea alba have a lower incisional hernia rate. But let's keep that in mind. Keep in mind this very thin structure, which we are told is important to close, to approximate the midline as being the key. And let's go forward. Now here's a caricature of a hernia. This is not a shark swimming underwater. This is the spine, and you have your abdominal wall, and we have a hernia here. And these are our back muscles. Now core stability works by having a complete ring of muscle and tendon. As soon as you break that circle and you turn it, as you have here, into a C, we lose core stability. And we rely on standing up by using our back muscles. And that's why people with large hernias tend to have sore backs. And most people looking at this caricature will say, oh, this is be an easy hernia to fix because there's no loss of domain. Well, when you bring this point to this point, you will produce a smaller volume in the abdominal cavity. This, the shaded area, is your effective loss of domain. And therefore, pressure has to rise in here, and the forces on here have to go up. Now, you can lengthen the abdominal wall. We know about these options. And you can reduce the volume, weight loss, or by chopping things out. But these are not always options, but they are part of your preoperative workup of the patient. Now, we're familiar with intra-abdominal pressure. We have closed our abdominal wall. So we have a pressure, forces acting on the abdominal wall, and we can summate all those forces into one. Unfortunately, they seem to be focused on our repair. Obviously, the abdominal wall is not purely elastic. It also has muscles which work by resisting that force by pulling. And this poor old repair is getting a lot of effort worked on it. Now, we may have a mesh, an onlay mesh in this situation. We have it fixed to the fascia in some way. But on day one, as soon as the patient wakes up, there's no tissue ingrowth. We are relying purely on mechanical strength. The strength of our closure of the midline, and the strength of any attachment of that mesh to the abdominal wall. And if it's enclosed within the abdominal wall, the other factors like slipperiness, that kind of thing. So closing that key bit at the end of the repair is very important. And I see this done time and time again. People start at one end and they start sewing and they pull, so this is tight. They put the next stitch in and pull, this is tight. And behind them, there's little tears happening because all the force to close the abdominal wall is focused at this point for a very short period of time before we get the next stitch in and the focus comes to the next one. And this is my preferred way of closing these large abdominal wall. I start with a suture either end. I put my sutures in very loosely, and then I work them together, almost parachuting the tissues together, spreading the load to try and prevent. Here they are. Here's sutures in from here to here to here to here, long sutures up to the hilt. I have no free suture material left. And then I work the tissues to bring them together, spreading the load. So don't put all your eggs in one basket. Don't put all the force on one point. You need multiple points. And we also have to think about the abdominal wall. The anterior rectus sheath has fibers which tend to run parallel to the floor. We're putting our sutures in. This is a magnified view. Here's our sutures that are going in. Then when we tighten them up, we pull, the suture tends to cut out through these lines of weakness because the sutures are running parallel to the strength of the fiber. Now we might say, well, that's why transverse wounds are better because we put the sutures in and we're at right angles to the strength and we bring it together. But if we put each suture through the same line of weakness in the fascia, yes, we'll get this closed, but we now have a hole above and a hole below. So thinking about where you put your sutures, how you put the sutures, perhaps near, far, moving them around, so the same tendon within the aponeurosis is not under stress, may affect how you bring tissues together. So think about the concertina working it together. The other thing about sutures is when you tie a knot, the knot might come undone, particularly with thicker suture. Tying a square knot is harder and you end up tying grannies, which will slip. And tying a knot deforms the suture, and that's a point of weakness where it can snap. So we have closed our anterior layer of our rectus repair, but I'm worried about my knot. So I go back and I do another suture, again using this technique of going in, out, in, out, in, out. Partly because this sort of technique will tend to cinch the material and hold it together. It also allows me to adjust tension. I've got this together and I'm so pleased I've closed the abdominal wall, but it's a bit baggy at the top and a bit tight here. So I'll go close to my old suture line here, and I can creep out at this point to bring the tension a bit closer, so we have tension equally distributed across the wound. And here's the concept of the 2 rows. Because it's an inverting suture, if these sutures want to slip, they will start to cut out through the tissues, but they will get caught up in this in the second layer. And you're saying, oh, a great idea, what's the evidence? Well, I don't have any evidence. But what I do have is my own t-shirt. And these are pictures of my t-shirt that I took 2 nights ago when I was preparing this talk. Here's the bottom hem of my t-shirt, and it's got 2 suture lines, here and here. And if we flip the t-shirt over the other way, we can see this suture line corresponds with this suture line here. Okay? The edge of the material that's going to fray and fall apart has been whipped. And the second suture line here is purely just to keep this flap down. But the key strength of stopping my t-shirt hem falling apart is this suture line material here. So having some good tissue, having tissue that's got interlocking stitches in it to stop it falling apart. And industrial sewing is designed to stand the test of time, and we need to learn from that when we're closing the abdominal wall. I'm sure many of you are familiar with the technique, but I'm going to rattle through the operation just again. You're talking about a midline case, and this gentleman was in the wars. He's had an accident, he's had a colonic injury, he's had a defunctioning stoma for a period of time, he's been reversed, there's been 1 attempt at a retromuscular repair, and this is a big, tall gentleman who looks pregnant. So the technique is pretty straightforward. Excise the skin, raise skin flaps back to healthy tissue, do your laparotomy through the center of the hernial sac, do your adhesiolysis, then decide which flap's going up and which flap's down. Here, the hernial sac is being attached to the posterior rectus sheath on this side, the head's up here. And there's where anterior rectus sheath becomes linea alba, so we're opening that. So on one side, we have a good posterior flap, but we don't have much. We want the anterior rectus sheath stops at the medial edge of the rectus on that side. On the other side, again, it's a bit sticky because this had been a previous retrorectus with a biological mesh. So the flap is being attached to the anterior rectus sheath, and we will have a smaller posterior rectus sheath here. Put in all our stitches. I'll look at that.
Can you speak a little louder maybe, or closer to the mic?
Yeah. So again, I've put the stitches in so that, and you bring them together. Here it's together. Where the blue lines are, we have posterior rectus sheath to posterior rectus sheath. Here's the medial side of the posterior rectus sheath on one side, the medial side of posterior rectus sheath on the other, and this is the flap in between, giving a little bit of tension, but at the same time allowing complete closure at the back. Put the mesh in and close the front. Same that technique, inverting so the stitches disappear. And I've inked this line. This is the anterior rectus sheath of the left. That's the medial side of the anterior rectus sheath of the right. And this is the little bit of hernial sac that was required to bridge the gap. And I understand that Dr. Kallinowski has done some work on this from the grip side, showing that actually this does impart a fair degree of strength. Skin's closed. And here he is 2 years later with muscle definition, with a flat abdomen, and it seems to stand the test of time. But people say, well, you want to get the midline. We're told to bring the midline together. You want anterior rectus sheath to anterior rectus sheath. This is a very interesting paper that's come out from our colleagues in Sweden, who are also proponents of the peritoneal flap. They have a modification of the technique. That's why they call it the modified peritoneal flap. And they have just published this year in this journal their standard retrorectus sublay repair versus their modified peritoneal flap. Now, they started doing this operation in December, so this series includes their learning curve. Interestingly, the modified group had slightly bigger hernias. Interestingly, they had more concomitant GI surgery, and there was more often a stoma involved. And data they didn't give figures for, but they said this group also had patients with higher comorbidity. So I'm setting this group up as the group to fail because they had bigger hernias, more concomitant surgery, stomas involved, and were less fit. and our standard retrorectus should be the key. Well, this is their results. Now, these timeframes don't entirely overlap, so there is longer follow-up, but short-term complications were the same. They had a questionnaire that they sent to patients, and patients with a modified repair satisfaction was higher. But for me, this is the astounding outcome. This is our standard, our current gold standard retrorectus repair. This is a modified, dodgy technique invented by deBeaux and Tullow. This includes their learning curve, and there's almost an order of magnitude reduction. Yet they have all the bad features in them: bigger hernias, more contamination at the time of surgery. So what's happening? Why is a peritoneal flap working? I think the biggest mistake was we called it a peritoneal flap. We should have called it the hernial sac. But perhaps using the flap allows less narrowing or reduction in the diameter of the abdominal cavity, thinking of the abdomen as a cylinder. So allowing a bit more volume means less tension on the suture line, and it's more likely to heal up. And perhaps the flap is stronger than native linea alba. And I don't have any science to say it's definitely stronger, but let me give you a few observations. Remember, we talked about the orientation of fibers in the anterior rectus sheath, and sutures could cut out along the line of weakness. We know that scar produces a chaotic scar, so sutures going through a chaotic scar will have interlocking fibers, making a thinner tissue even harder for the suture to cut out. But the hernial sac is not thin. Remember the CT scan I showed you of the linea alba? You could hardly see it. Look at this hernial sac. That's pretty strong. It's hard to put stitches through. It's solid tissue. Now, we've been accused with the peritoneal flap technique of making bridging popular again. Now, we have a lot of bridges around us. This is the first or fourth, and every decade in the last 3 decades, we've built another bridge across this stretch of water. But I put it to you that the peritoneal flap is not bridging, but involves biomechanics, the strength of tissues, the understanding of tissues and the elasticity of tissues without science behind it, but an understanding of those things to make peritoneal flap work. And here's an example, and this is what I call the deBeaux sign. It's more applicable to women. This is a lady beforehand after gynecological malignancy, a huge defect, and I'll show you her CT scan next, and this is her sometime after repair. And it works for both men and women, the deBeaux sign, but the higher that the patient lifts their top, and particularly in women, if they lift it above their breasts, the happier they are with their surgery. And let me show you this lady's CT scan beforehand. Large defect, there's a little bit of rectus muscle on this side. There's no rectus muscle on that side. So what midline should I bring together? I don't know. Should I bring this edge to this edge? That's not going to be achievable without removing half of her abdominal organs. But here she is several years later. Abdominal wall is now a cylinder, so she has a functional core stability. Yes, the rectus muscle hasn't regrown. We haven't got that ability to regrow rectus muscles, but we have an intact abdominal wall.
Andrew, can't hear you really.
Sorry, we have so I'll say that again because I think I was covering. Here's a little bit of rectus muscle. No rectus muscle on this side. We're told to close the midline. What am I going to close? This to this? There's no way that will go. I need to use the hernial sac. Here she is 2 years later, roughly 2 years later. No rectus muscle for sure. It won't regrow, but we have an intact. We have a circle, a cylinder, a core stability patient who's happy. Why have we focused so much on the linea alba? I think we have had a fixation about linea alba and the so-called strength of linea alba because this is how we draw it. We draw it as some very thick, tough thing that if you put your stitches in, it'll hold together. But in effect, we're bringing together some very weak tissues, and perhaps the hernial sac is much stronger than this, is stronger than native anterior rectus sheath, and will give some inherent strength. That's been a bit of a madman's ramble through some maturation of surgery over the years, but I go back to grip. Grip helps you think about what you're trying to do because it has a major feature of hernia size. So the bigger the hernia, you got to think, what am I doing? I have to do a good job here, and you have to take a lot more care. Then you're going to put the biggest piece of mesh in that you can, that will fill your space to maximize ingrowth with time. But remember, day one, tissue ingrowth has no part to play. You don't have any ingrowth on day one. You just have the mechanical stability of your repair. The sutures that you put in, the tissues that you brought together, as soon as they wake up, their first cough, that's all you have to support your tissues. But bear in mind, your mesh may help you if it provides some grip and is not slidey. How do you put it all together? Where do you put it? And how do you close your defect? All makes a difference. So for me, grip encapsulates all you need to do when you are thinking about a patient in the run-up to your surgery. Now, I'm conscious in the interest of time, I've done a high-speed run through that, but I've done that to leave some time for questions. And the key message is keep a grip on your grip. Thank you.
Thank you very much, Dr. Andrew, for that wonderful talk. I now request Dr. Kallinowski for his comments.
Dear Dr. deBeaux, as all the time, it's really fascinating to listen to your experience and to listen to your experimental results, clinical results, and your thoughts behind it. I'm deeply impressed, and I really have to congratulate you for your lifelong, year-long work on this topic. When I want to comment on it, I just can say it's all right. You know, whatever you said, it's right. So just let me ask or put a few thoughts to it. You know, when I listened to your talk, I saw slide 3 after your title page or title slide, and I thought this CT slide is a fascinating slide because you see sort of an example of mesh migration. I'm quite sure that you placed the mesh centrally over the defect, and if you look on the tags, they are with a different distance on both sides of the edges. So what happened is during the first period, the stress on the abdomen by whatever motion, coughing, splattering during extubation by anesthesiology friends already shifted the mesh with the tags, you know, to the side. And there is a publication out by the Smietansky group in July this year, where they looked at tags in clinical biomechanics. It's in clinical biomechanics, and they looked at the tags on ingrown meshes, sort of ingrown meshes. And when they looked at these tags during motion of the patient shifted those tags and their meshes by several centimeters by simple bending and moving and doing sort of everyday motion. So either the mesh of this Polish patient has not had a stable ingrowth during the observation period, or we do not know now whether an ingrown mesh has just elastic connective bonds between the mesh and the tissue we used at the mesh placement. So this, I think, is a very fascinating and very good example, and we all know those CT scans when we look at our patients. So
if I could just answer that up front, because my memory's not too good. I think you're right. I think I do have a feeling that abdominal wall repair failure starts as an early event. It may not manifest till later, depending on how catastrophic those early events are in shifting your mesh. We would have aimed to have the mesh as centered as we could. We know that there's some parallax error, and you tend to put the mesh in off center because what's close to you looks bigger than what's further away, but we try and use sutures to help position the mesh. So we are fairly confident we put it in square, but it has clearly moved. We also understand a little bit about tissue integration, and that's quite variable. And I have to say the meshes that I've removed when I've gone back in after a failed IPOM, I'm disappointed at how easily that IPOM mesh separates off the tissues. The ingrowth has been relatively poor, and therefore you can understand why they move. But that may also reflect the early days when we used to make no attempt to take down the falciform ligament or take off any peritoneum. We just slapped in a mesh. So we were attaching a mesh to preperitoneal fat, to peritoneum, so that it could move. But to recap all of that discussion, I do wonder the early events, the first few coughs, the first few days when you only have mechanical strength, you have no tissue integration, are the key factors which start some repairs to fail.
Just to put sort of a term to the discussion, addressing Dr. Karatas, you know, the term is shakedown. You know, if we look at how the tissue ingrowth happens, we probably have to realize that any weak area, as Dr. deBeaux pointed out, any weak area might be due to some technical reasons during surgery, might be due to some early occurrences during recovery, is enough for the whole reconstruction to fail due to what the technical people call ratcheting shakedown. If ratcheting shakedown does not come to an end, we will have a recurrence. So this is just a term which will, I think, which will sort of follow us for some longer time. And so last time we called it shakedown or breakdown. And I think this is what the point at this moment is. The other thing, the mesh defect area ratio concept, as Dr. deBeaux pointed it out, was developed on this class BNC meshes. You know, we talked about dynamic impact strain, and if we look at those meshes, some of them are sticky and others are less sticky. And Dr. deBeaux asked, why do people focus on the 5 centimeter overlap? And I think this is due to a publication by Lyons et al. I think it was in 2013 or 2015, somewhere around this time, where he did some bench experience with pushing a mesh through a defect. And he found that whatever mesh you push through a defect, for a 5 centimeter defect, a 15 centimeter round mesh, so an overlap of 5 centimeter, they always are safe. And then he applied all kinds of biomechanical models, and it was always the same result: 100% safety, 5 centimeter defect, 5 centimeter overlap. And since we surgeons tend to like these kind of relations, this, I think, got very fast spread virally, and everybody knows it now without really knowing where it comes from. But I think this has to be attributed to this excellent work by Dr. Lyons. This is what I call static stress. You know, he pushes it through, and dynamic stress, as we with dynamic.
Dr. Kallinowski, we are not able to hear you now. Are
Yes.
you muted?
Can you hear me now again?
Yeah,
It's better.
Now
Thank
hear
you.
you. Friedrich, if you allow me a moment, when you were talking about Lyons and the paper, I could just share a couple of slides from that paper, so you could just talk about that. Want that? Exactly what you're referring to.
Yes, please show the slides.
Okay. No, I'll just show you this one. Can you see this?
Yes, this is the right slide. Okay, this is the work by Lines. You see 2015, British Journal of Surgery, see?
Yeah.
And
So
there you
it's
see...
not 5 centimeters actually, it's twice the diameter of the hernia with plus 25 millimeters, 2.5 centimeters.
That's right. And you have 100% safety, and people discuss whether 12.5 is enough and so on and so forth. That's this work, right? And I think it's an important step, but the next step is that the surface, I mean, this is the slipping of the mesh observed on an explant. You see those tags being slipped sideways, and I think this is the force result of the slippage. So, we try to classify the meshes, and I think this is the minimum we need to. Yeah, this is the story of Snow White. It's like an apple which is with poison, you know, and poisoned apple. That we always think it's an overlap of 5 centimeters. This is what Dr. deBeaux just said. It's a sort of a trap, you know. Is there an optimal size mesh? It depends on the hernia size. So, okay, so you have to have a larger MDAR for larger hernias or for more slippery meshes. The next thing, the peritoneal flap repair, I think, is a true advancement. I have to congratulate it to you. I've visited Agneta Montgomery in her hospital, and I spent a couple of days with her when I sort of came out of the bench test work and started to apply it clinically. And I found this technique, she attributed it to you, and I think you both published in May last year excellent results on the technique. So when you need to have a large sort of area to place your mesh on, the peritoneal flap repair is what you should do. And 2 considerations. What about suturing the defect with barbed wire? You know, you showed it with a technique, but we could compare on the bench test whether different wires, different suture techniques, barbed wire, or the new on the market mesh wire. It's now with an, you know, it's a meshed piece of nylon thread by an American guy who works for the, I forgot his name, but it was a very clever design of a new type of suture with much more. Sorry?
Yeah, Ramana.
So I think this is probably worth combining it with your approach, Dr. deBeaux, for even further advancing the peritoneal flap repair. In the journal of the Scandinavian Journal of Gastroenterology, you showed where the question was, is the retrorectus repair really less good than peritoneal flap? I miss the mesh size, you know, I miss the hernia size is given, but I miss the mesh size because my my idea would be that the mesh size would be larger with a peritoneal flap repair because it's much easier to put a larger piece of mesh in with this type of repair. So
yeah, I don't think there was mesh size data given in Friedrich in that paper. There may have been an average mesh size, but I don't think there was individual mesh size and certainly no mesh diameter. But it's an interesting point because it's back to the pillar of grip, and that's your mesh defect area ratio. And if you can create a bigger space, which may be what TAR allows you to do in situations as well, that's maybe why the success of TAR or the peritoneal flap is just down to size of mesh.
You know, so I have to look the paper up. I have not been aware of it. So you pointed it out now, and I think we look it up. I want to show, I don't know, do you see it?
Not yet.
Can you see Can you see the slide I'm showing?
We're not able to see it yet, Dr. Kallinowski.
Not yet.
Okay, I try.
Yes.
Maybe you see it
Yes.
now. I hope.
It's visible,
Okay.
Doctor.
Because there are so many questions not answered yet. And I tried to put them into pre-operative, intraoperative, post-operative. My questions left to me after, having heard 2 excellent talks. How do you calculate the risks for your patient? And there is a SEDA app out there by Todd Hanniford, and it's all free for us to calculate what kind of risk we are running with our patients. And in the future, we might be able to optimize this risk with a better risk assessment. And intraoperative, at the moment, the surgeon tailors what he thinks is most important. And in the future, maybe some kind of application of the MDAR grip concept can better this for the surgeon, make it easier. And we have no really good rehab for our patients, because rehab is probably a major point for reaching shakedown. We talked about shakedown just a minute ago. So this is probably important. Now I try to shift to the second slide. Here. So, and the factors intraoperatively, we probably have to think not only about the size, but about the midline or lateral or combined or so on. So about some kind of class of hernia. And again, MDAR probably will give us a good idea about this. And then whatever the type of mesh the surgeon prefers, it's the critical resistant to impact related to pressure, which should be known for this type of mesh. It's another kind of looking at the grip concept. Fixation, people talk about crown or double crown or so on, but we do not really know on what microstructural size we have to space our load distribution, because when you have a dynamic impact, you put energy into the system, and the energy needs to be dissipated, and the dissipated energy needs at any point, at every point, to be digested by the reconstruction. Otherwise, you will have a failure and not have a shakedown. And this probably in the future will be pre-calculated due to some kind of computer algorithm. Maybe it's true, maybe it's not true. It's hard to make predictions about the future, especially if it's still going to happen. And if you have a procedure, the surgeon prefers something, but he should be able to assess what he gained with his reconstruction. So now we are at the gained resistant to impact related to pressure. And if you look at the tissue distension, at the moment, we do not really consider this for the individual patient. You said, Dr. deBeaux, that people always say the linea alba is strong, and you pointed out that it's not true. It's a nice narrative, derived from fancy sketches and drawings and textbooks, but it's probably fairly weak and elastic. And, the flaps reconstructing the defect might be stronger. And in order to get a handle on this, we could use computed tomography with an Valsalva maneuver. So it's CTAV, it's computed tomography of the abdomen with Valsalva's maneuver. And from this, we could assess the elasticity both directly, and we could use it with some more advanced computer programs. So I think for me, this is sort of the scope covered by Ramana. Excellent talk. Dr. deBeaux, even more excellent talk, if at any point possible. I think they both sort of one puts on the other, and I think there are still many things keeping us busy in the next 100 years. And I hope we all share this time together on those interesting Saturday afternoon. And since I had the opportunity to talk a lot as the only expert, letting me thank you for the time and the invitation.
Well, from my point of
Thank
view,
you,
it's been
Dr.
an absolute
Kallinowski, for your comments.
privilege to be here. And we do need to start organizing some GRIP conferences.
Yes, we do.
I would now request Dr. Ramana to give his comments.
Can you sort of stop my video being shown by everybody? I think I have to stop it, right? So here I'm gone. Thanks.
Okay. Very absorbing evening, and still continue to be more questions than answers in a lot of ways. For example, the question which Chinmay Gandhi asks, if there is muscular atrophy, there is denervation, what happens to the grip? How do you assess that? If you operate on an optimized patient versus a non-optimized patient, how do you figure that out? So I really don't know the answers to these questions because I don't use grip as a factor in my surgery the way that maybe the German surgeons in the Stronghold database do. So I really don't know what is the answer to these questions. Maybe Friedrich or Andrew can comment on that.
Well, I always like to answer questions that I know nothing about. But I think remember, grip is an equation. There's MDR, and then there are coefficients of other things. And so muscles will have an effect on coefficient of the elasticity or distensibility of the tissues. But you must remember too that in abdominal wall repair, muscles are important to make it work, but they are of no value in terms of affecting the repair. You can't stitch muscle to muscle. You can only stitch fascia to fascia, ponerosis to ponerosis, or a ponerosis to mesh or whatever. So you really, that's why when muscles disappear, I'm not so bothered because I know the fascial layers are still there and I can still bury my mesh in amongst those fascial layers. The muscles make it work, but when it comes to the repair, mesh sticking to something, you don't want the mesh sticking to muscle. Muscle to muscle interface will tear very easily. And Ram showed that very nicely with a poor guy lifting 250 kilos and he tore his muscle. Muscles often tear, but it's the tendon, the fascia that we need to focus on, and that's still there. Yes, it will be weakened in a neuropathic muscle because it's not being stressed. So it will have an effect because, remember, tendon responds to load, and if it's not being loaded, it will tend to go. But built into that grip equation is distensibility, which I think this will affect.
I think we talked about the holy plane of abdominal wall reconstruction. It's sort of the mesh tissue interface, you know, as Dr. deBeaux just pointed out, muscle, tendon, retention strength as given by Ramana. So this is sort of the holy plane of, and what we will have to chase in the future is the holy grail of abdominal wall reconstruction. How do we apply all these knowledge and all the knowledge we hopefully will gather at many points on this world, looking at the dynamic motions of our patients during the healing period, during the time of ingrowth, and so on. And once we reach this holy grail, we probably can answer the holy plane question much better.
I would now like to invite Dr. Pramod Shinde for his comments and questions, if any.
Well, I can say that it was an astounding and astonishing evening, and We have heard some phenomenal talks by all the three speakers, and they were almost like wonderful, beautiful stories that we heard. And we saw that Dr. deBeaux deliver his talk with some wonderful, it was almost like listening to a story, and with some wonderful pictures also, which we had not seen and which we are not very familiar with, the pictures that he showed, non-surgical pictures. And of course, Ramana's talk was all, again, like a story, beautifully woven and made easy for us to understand. And Dr. Kallinowski was like a sci-fi fiction story writer. But what I liked about all of them was, like, for example, Dr. Kallinowski really put our minds to a little rest, saying that although this appears complex, it's not all that complicated. It's ultimately just an equation and anybody can learn it. And he's also putting it on an app where it will be made very useful to use for any surgeon, and every surgeon would it be. Dr. deBeaux's talk was very, very crystal clear, very entertaining and very educating at the same time. And after having been popular and introduced to great concepts in hernia surgery, I could almost see that we could have one more research from him on the way we close the abdominal walls, because he had some original thoughts on the way how we suture. And also maybe that is also one great area that he addressed, that the way we suture can also have a great bearing on how the tissues hold together. And of course, Ramana not only educated us, but he did it in a very entertaining way, in a very nice way, and he made the concepts come real to us and with some very real life examples. I'm sure we will have much more to hear about from this great smart talk, and maybe we need to have an entire single theme conference when we have great pioneers like this talking to us and making the science easy for us and make us understand how this works. So maybe we could have a single theme event on this kind of topic. Thank you, all of you.
Dr. Shinde. So one last parting question. I was just curious to know if you have looked at the weight of the mesh and what weight would probably be the right one to be used in a regular practice. Have you ever looked at those aspects in your biomechanics, Dr. Kallinowski?
Did you ask me a question? I thought.
Yes, sorry. Would you like me to repeat it?
Yes, please.
I was just curious to know if you looked at the weight of the mesh for a regular hernia closure. What weight of a mesh would be ideal? Have you ever looked at it? Do you have an answer for us? Because we are always confused with what kind of a weight would be an ideal weight to be used in regular practice.
Yes, there are many questions open related to meshes. You know, for example, can you get some kind of physical properties on the surface of the mesh relating to the slippery factor? And you're right, you know, the weight has something to do with the question, how good does the mesh take up acceleration during a dynamic impact related to the tissue? You know, at the moment, people try to sort of simulate the abdominal wall anisotropy with the mesh anisotropy. And in the future, maybe, I don't know, but maybe the dynamic of the impact is as important, and the weight and the density and those mechanical properties of the mesh will very much influence this potentially. But we have to my knowledge, no data on this important question.
Maybe Dr. for the clarification.
I have none.
Yeah, I think that's true. It's a concept. As you can imagine, you put some tissue into the abdominal wall, you fix it somehow, and then you give an impact to the tissue. You want the mesh and the abdominal wall to expand at the same speed, the same rate, in the same way. If you don't, then at any fixation point, there will be additional force as that fixation tries to stop the distension of the abdominal wall. For example, if the mesh is less distensible than the abdominal wall. So that's part of the Holy Grail, is replacing like with like. And we know that meshes were over-engineered in the past. And we know that people are different, and we know that different parts of the abdominal wall are different. So making a mesh that will match the host will always be a challenge.
Thank you, Dr. deBeaux.
In the future, sorry, maybe in the future with 3D printing, we could have an individualized mesh for every patient.
Yeah.
Wow.
Maybe.
Wow. So if there are no more questions from the participants, I think I would like to thank all the speakers for a wonderful thought-provoking evening where they've given us a lot of evolving concepts which we can probably look forward and utilize in our day-to-day practice to have a much better outcomes for our patients and have a durable repair. Thank you once again, AWRRC, for this wonderful session. Until the next program, bye from all of us. Thank you.
Thank you.
Thank you.
Thank you very much. Thank you.